Stage 1 is non-blanchable erythema of intact skin. Intact skin with localized area of non-blanchable erythema, which may appear differently in darkly pigmented skin. Presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. This may indicate deep tissue pressure injury. Stage 2. Partial thickness loss of skin with exposed dermis. The wound bed is viable, pink or red, moist, and may also present as an intact or ruptured serum-filled blister. Adipose or fat is not visible and deeper tissues are not visible. Granulation tissue, slough and eschar are not present. These injuries commonly result from adverse microclimate and shear in the skin over the pelvis and shear in the heel. Stage 3. Full thickness loss of skin, in which adipose or fat is visible in the ulcer and granulation tissue. An epibole, rolled wound edges are often present. Slough or eschar may be visible. The depth of tissue damage varies by anatomical location. Areas of significant adiposity can develop deep wounds. Undermining and tunneling may occur. Fascia, muscle, tendon, ligament, cartilage and/or bone are not exposed. If slough or eschar obscures the extent of tissue loss, this is an unstageable pressure injury. Stage 4. Full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and/or eschar may be visible. Epibole or rolled edges, undermining, and/or tunneling often occur. Depth varies by anatomical location. If slough or eschar obscures the extent of tissue loss, this is an unstageable pressure injury. Unstageable. Obscured full thickness skin and issue loss. Full thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed, because it is obscured by slough or eschar. If slough or eschar is removed, a stage 3 or 4 pressure injury will be revealed. Stable eschar on ischemic limb or heels should not be softened or removed. Deep tissue pressure injury is persistent non-blanchable deep red, maroon or purple discoloration. Intact or non-intact skin with localized area of persistent non-blanchable deep red, maroon, or purple discoloration, or epidermal separation, revealing a dark wound bed, or blood-filled blister. Pain and temperature change often precede skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury may result from intense prolonged pressure and shear forces at bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of tissue injury or may resolve without tissue loss. Do not use deep tissue pressure injury to describe vascular, traumatic, neuropathic or dermatologic conditions. Medical device-related pressure injuries result from the use of devices designed and applied for diagnostic or therapeutic purposes. The resultant pressure injury generally conforms to the pattern or shape of the device. The injury should be staged using the staging system. Mucosal membrane pressure injury is found in mucous membranes with the history of a medical device in use at the location of the injury. Due to the anatomy of the tissue, these injuries cannot be staged. Hospital-acquired pressure injury is any pressure injury or wound developed after admission. Community-acquired pressure injury is a pressure injury documented as present on admission. Documentation of community-acquired pressure injury is important because if not noted on admission, the pressure injury will be considered a hospital-acquired pressure injury. Unit-acquired pressure injury is any new pressure injury developed after arrival in the unit. Wound measurement. Measure widest width of the pressure injury side to side perpendicular 90 degrees angle to length. Undermining is the tunneling wound that begins directly under the wound edge. Tunneling or sinus tract is the narrow channel of passageway extending into healthy tissue. Geography of chronic wounds. A. Wound bed. B. The wound edge. C. The surrounding skin. Wound bed assessment. To describe the tissue present in the wound bed using percentage, should equal to 100%. Wound bed characteristics. characteristics must have a total of 100%. Wound bed include the following. Epithelial tissue is the pink or red. Granulation tissue is the beefy red. Slough tissue is the yellowish covering. Necrotic tissue is the dry, dark, leathery covering. Wound edge are the following. Intact, the wound bed is in the level of skin. Attached wound edge is connected to the wound or sloping edge. Unattached wound edge appears as a cliff, rolled edge or epibowl. Edge is not connected to the wound base. Epithelialization is a healthy tissue growing from edge of the wound. Fibrotic wound edge. Calloused wound edge is common to diabetic wound. Exudate amount. If the wound is dry, wound has a scanty or minimal, moderate, and heavy. Exudate drainage or type R. Serous, sanguineous, purulent. Peri-wound skin or skin surrounding the wound. These are intact, erythema, heat or warmth, edema, indurated, macerated, excoriated or denuded, calloused, and fragile skin. Wound pain. Verbal response or if patient is comatose displaying any of the FLAC Tools 3 pain indicators, refer to and complete the pain flow sheet. The nurse must notify the wound care nurse for the following wound characteristics. Presence of slough and necrotic tissue, purulent type of exudate. Wound is malodorous after wound irrigation. Presence of bleeding. Peri-wound skin are heat, warmth, presence of erythema, edematous, indurated. Wound treatment and diagnostic procedure. Wound treatment such as dressing materials used and their effect to the wound, irrigating solution, and secondary dressing, such as silicone foam, bandage, and adhesives. Documentation. Wound care is highly specialized area requiring well-developed observational skills and knowledge. Not documented considered not done. Good documentation will lead to appropriate treatment, evaluation of healing process, medico-legal related investigation, following patient updates. Forms. Utilize initial and reassessment nursing database. Nurses' progress notes. For skin assessment, risk assessment tools such as Braden Adult and Braden QD. Pressure injury wound care flow chart. Treatment plan and standing order. Conclusion. Comprehensive skin and wound assessment and accurate documentation facilitates maintenance of skin integrity, wound diagnosis, and management plan in order to prevent skin damage, treat wounds, prevent further wound infection, and promote healing. That's all. Thank you.